It gives me great pleasure to introduce Professor Thor Wager for the grand rounds. So Dr. Wager obtained his PhD in psychology from the University of Michigan, Ann Arbor in 2003. And then he moved as an assistant professor to the University of Columbia in New York, where he worked between 2003 and 2009. And then he is currently a professor of psychology, neuroscience, and a professor at the Institute for Cognitive Science at the University of Colorado in Boulder. His research has focused on the neural basis on psychophysiological effects of emotions, pain, stress. His laboratory has used multiple tools, including fMRI, psychophysics, psychophysiology, and sometimes other techniques like EEG, PET, and TMS. His most recent and very famous work led to the development of the neurologic signature of pain, and this paper has been published at the New England Journal of Medicine using machine learning tools. So without further ado, I'll leave the floor to Thor.
Let's see. Is the mic on now? Oh, good. Great. Well, thank you so much for bringing me here. I'm delighted to be here to speak to you today. I am moving to Dartmouth from beautiful Colorado to beautiful Hanover, New Hampshire, turning over a new leaf, so to speak, July 1st, and recruiting a new lab and group. But that's not what I'm talking about today. If you're like me, you want to help people, and you want your science to do something good for people, develop interventions, and so forth. But there's so many interventions to choose from. Consider the Ebers Papyrus, circa 1500 BCE, one of the oldest known pharmacopoeias. Some of its 700 treatments seem familiar. Like if you had a headache, you might be given wormwood and opium, an analog of present-day absinthe. If you were poisoned, though, you might get powdered emerald or other stones, or bezoar stone, which is undigested matter from the intestines of an animal. Later, and some of these treatments lasted for centuries, you'd be treated with human sweat, feces, animal feces, tapeworms, usnea, powdered Egyptian mummy much later, or one of my favorites, moss scraped from the skull of a hung criminal. These treatments were given to those who could afford them, even the most wealthy and powerful among us. This is the case of King Charles II, who died from an unknown ailment, at least by me. They first extracted a pint of blood from his shoulder. They gave him an emetic, an enema, shaved his head and raised a blister, which is an analog of modern-day cupping. You can see this in the Olympics now. Sneezing powder, emetics, bleeding, pigeon dung on his feet, 40 drops of extract of human skull, so it is real, and the bezoar stone, and then he died. And we might roll our eyes at the physicians of yore, but many of our modern treatments are not doing much better, especially when it comes to pain. So there are a number of treatments that are insurance reimbursable, widely used surgical interventions that people really just believed have to work, including arthroscopic knee surgery, vertebroplasty, epidural steroid injections for back pain. All of these have in common that when they were later tested after widespread use in randomized controlled trials, they don't beat placebo in those trials by and large. This is one surprised me, a New England Journal paper recently on stents for angina, and other emerging treatments that many of us are very hopeful about, like gene therapy for Parkinson's disease or deep brain stimulation for depression. And incidentally, placebo effects are growing across time, but drug effects are not. And this is posing a problem for clinical trialists and for drug developers because more and more trials are failing. This is one of my favorite examples because it's about Parkinson's disease, which is a neurodegenerative disorder. We don't know that people can just get better. For Parkinson's disease, this was an industry-funded trial that followed Parkinson's patients over 2 years. You can see motor score improvement here. They get better and they stay better for 2 years. But the trial failed and the drug company was thus sold off for parts. Why? Because people in the placebo group also got better and stayed better for 2 years. I draw two conclusions from this. One, Symptoms are often a poor guide to treatment selection, even though they're very important. We need to understand and measure pathophysiological mechanisms, which can be difficult. And number two, the psychosocial context and meaning might actually be really important. And so psychological treatments might help alongside of other mechanistic treatments or even interacting with them. I'm going to focus a lot on pain as a case study for a variety of reasons, including that we've decided to study it. But it's a root problem. It's a symptom across many, many disorders. And it's increasingly thought of as a disorder in its own right. It affects 100 million adults. It's the primary reason people seek medical attention, and it costs us every year on the order of a U.S. military size budget, give or take. But there is no biological measure for pain. Pain is measured with this cup and other kinds of scales. So you can see here there are faces from frowny to smiley faces. There are numbers, and pain, the word pain written in multiple languages. This was actually the cup that was given to my wife when we had our third child and she was in the hospital. So actionable treatment decisions were made. This causes a lot of problems. This is a case study. 65-year-old male, back strain while loading a suitcase onto an airport conveyor belt. 2 weeks later, the pain continued. They suspected disc herniation, but he had normal MRIs of spine, pelvis, hip. Everything looked normal. He had 5 months of physical therapy, acupuncture, everything, no relief. His pain moved from one place to another in his buttock, loss of strength in the hamstring, radiating pain. They suspected nerve entrapment, but treatments for that, like steroid injections, were not effective. And as time went on, this is in his words, he says, various clinicians offered suggestions. Some wondered whether the pain was becoming functional, which for some people is code for made up. He started showing signs of depression. And people asked him, are you really that happy with your job? It turns out he was that happy with his job because this is Philip Pizzo, who was the former dean of the Stanford Medical School and the chairman of the report Relieving Pain in America. And that case study was taken from his editorial in the New England Journal of Medicine, where he said, I thought I knew a lot about chronic pain until this happened to me and I got it. And it was a whole new education. And fortunately, he has a happy story where it was discovered that he had piriformis syndrome. It was a nerve, essentially abnormal nerve branch. This was, taken care of physiologically. But for many of us, we wouldn't get that same process of diagnosis. And even for him, it was remarkably difficult. We're learning a lot in many ways about what pain is not. And still, people really think, boy, if you have a bulging disc or degeneration, that's really probably a good sign that you might need surgery. However, if you look at all these numbers, what they mean is that disc changes of all of these kinds are typical in the population without any pain. Even if you're 20, 30, 40, people have these abnormalities, and by the time you're into your later ages, 70, 80, virtually everybody has got something that looks wrong with their back, but that doesn't mean you have pain. So across now a large literature, spinal MRIs are not very diagnostic. It doesn't mean they're never useful, but they're not certainly indicative of the cause of pain in many cases. In addition, herniated discs, like the one that you see here at the left, I'm sorry, the projector is sort of going a little bit in and out, so it might be hard to see. There's a bulging disc there, and in 1 year, the next year, it's gone. The disc has been resorbed. And in fact, most of the time, that happens. So there's this increasing idea that we have to look at the brain for answers. And if you look at animal models of neuropathic pain injuries, there are multiple varieties of these, but many of them involve a partial nerve injury, which produces persistent pain in an animal, and accompanied by neuroplasticity and changes in inflammation and neuroinflammation. And as a quick snapshot, there are multiple loci from the spinal cord up into the brainstem and amygdala pathways. That's some of Steve Waxman and colleagues' work right there. The anterior cingulate, the nucleus accumbens, the somatosensory cortex. In all of these places, there are neuroplastic changes that happen after injury that we think maintain the persistence of pain. And in multiple cases, there are interventions that can cure pain in rodents, essentially, and remove pain behavior. Unfortunately, we haven't got there in humans. The questions that I want to ask here are, which of these mechanisms are relevant in humans? And for that, we need human brain studies to translate and fill the gap. What we need to know is, what's the locus of pathology in a given patient, if it's Philip Pizza or somebody else. And that's essential for understanding how we should intervene. If somebody doesn't have spinal pathology that's driving pain, they probably shouldn't get spinal surgery, because 20 to 40% of those surgeries fail and make pain worse than it was in the first place. So here we have multiple brain targets. There are classic nociceptive systems, like the spinothalamic system. There are systems more closely associated with fear and avoidance, like the parabrachial amygdala system. And there are those associated with motivation and hedonia, and, as I'll show you soon, pain avoidance, which include the VMPFC and nucleus accumbens system. So behavioral control. The vast majority of pain drugs act on these circuits in complex ways that we don't fully understand. So we need models to help us understand what's driving pain in populations and in individuals. And a model of pain, like this early model of the solar system, is one in which you ideally would specify what the parts are and how those parts interact. And that's really a set of simplifying properties that help you explain a phenomenon much more easily. So for a model of pain, we like to have a set of potential mechanisms and how they interact. And of course, that's quite complicated. I'm going to focus on human brain imaging here. And this is, you could think of this as a proto-model. We can deliver some noxious events that are painful. We're going to use patterns of brain activity as potential biomarkers or measured patterns that track pain intensity. That's not the only kind of biomarker, but it's a place to start. And why do we want to do this? Well, we're not trying to recapitulate pain or just provide a different measure, and we're not trying to say we don't trust people's pain reports. We're trying to treat pain reports as data and say, okay, you have pain. Let's see if we can find something that's linked to that. And that's physiological. So these are symptom-linked biological measures, which then can be studied in their own right. Where I'm headed today is we can test available interventions, things we already think work, and see how they work on these mechanisms or these systems. We can scale up the ones that hit those targets. We can also use other kinds of data to link those pathways to a variety of other things that we know from animal models, from other studies. Like now, even in human brain imaging, RNA sequencing maps are available to link to these pathways, and they're going to become more available over time. And then we can find interventions that target those mechanisms. At a minimum, a biomarker ought to be sensitive and specific to what it's purported to measure, the category events like pain. But the problem with imaging has been that it's not. And we haven't assessed its sensitivity and specificity. So in the old days, how do we test an intervention effect on pain? Well, we find the areas that respond to noxious stimulation, that seem to respond to pain. And then we can look at those under control and treatment, that's red and blue. We see a reduction, and we say, yep, it worked, great, let's go on. This, by the way, is a placebo intervention. Come back to that later. The problem with this is, even if you look at the most pain-related portions of these areas, like the anterior cingulate cortex here, you can now start asking, what are all the different possible things that could activate it? Is it really selective or specific for pain? And this is a plot I'll show you from a program called neurosynth.org. It was built by Tal Yarkoni when he was in my lab a few years ago, and it's still up and running, so you can search it and do this online yourself. Well, this is all the things that activate that particular location. So if a placebo or other intervention influences activity here, we don't know that it's affecting pain-related signals it could be a variety of different motivational or even language-related processes, emotion, etc. So we really need better targets. And this is where the measure that Dr. Jeha was talking about comes into play. One of the first things we did in this space is to try to identify a brain signature for pain. We take a training sample and, in brief, subject them to multiple levels of noxious stimulus intensity, so 4 levels from barely painful to as much as people can tolerate. And then we build a model to track how much pain they're feeling. And this is training under ideal circumstances, really, when people are reliable, good raters. And then we can test it under circumstances where we're more suspicious, or even we can't measure pain at all. So we've, for example, got one thing that's in progress. I'm looking at this to test pain in infants who can't report pain at all. This signature is a linear pattern of the weights that basically combined are most predictive. We can make inferences about the pattern itself, which we called the neurologic pain signature because the journal editors asked us to call it that, and we did not want to tell them no. So there it is. It involves many areas that are nociceptive targets involved in pain. Anterior cingulate, anterior mid-insula, medial ventrolateral thalamus, somatosensory cortex, and posterior insula. Those are all validated regions that are involved in pain in humans and animals in a variety of ways. So that makes sense. But it's not just that we have activity somewhere in the anterior cingulate. What's important is that we've precisely specified a center-surround pattern that we can test and replicate across studies. And in fact, we can take that pattern, which is a pattern of weights, take a new sample, and apply that signature by taking person by person, individual people, and taking the data images and applying the signature, which means calculating a weighted average, where the signature supplies the weights. That boils the image down to a number, which is the predicted pain in this case. And then we can test its properties across studies. So here's an example of an application to a new study. Each line is a person, there's increasing levels of heat, and you can see that the lines go up for most people. We can take that continuous readout and turn it into a classifier and say, okay, here's 2 different images, which one's associated with more pain for a given person? And if we do high versus low in this case, we can get it right about 96% of the time. And that's been typical of our target across studies, performance across studies. We've tested this in many different ways now. And this isn't the main focus of my talk, as you'll see, so I'm going to move through this and go on. But I want to use it as a way of elaborating on the marker development process or measure development process. So these are all things that activate this measure, multiple types of pain, somatic pain, and possibly a few things that are confusable somatic experiences, like aversive taste, but those are still sort of in progress. So we're actively trying to find things that are not pain that activate this, and then we can develop better models. It's not activated by a number of different things that are otherwise confusable with pain and have been claimed to activate the same areas in a very large literature now, including aversive, horrible, disgusting images, looking at the person who rejected you in love, observing somebody else in pain, anticipating pain. In some preliminary studies, nausea and itch. That's with Vitaly Napadov's data. And cognitive demand by itself, recalling pain, and non-painful warmth. So we're actively testing that as well. And so far, the profile looks like it's fairly specific for somatic pain across multiple body locations and types. This is one example of this, and this is a meta-analysis of pain and placebo effects with this whole group of people that I'll show you here. And we gathered together then the person-level image data from 600 people across 20 studies. So each of these rows is a study. The shift to the right means that our pain signature, NPS, responds to pain. And the dots are individual participants. So what you can see at a glance is that it responds across multiple types of somatic pain. There are very large effects. The effect sizes are over 4 times as large as the typical responses For example, nucleus accumbens reward signal, or premotor cortex motor signal. The effect size is about 0.5, which is moderate. Here, it's over 2. And what that means is that 95% of our individual participants respond. We think that it works, in part, because it can capture information across multiple systems and regions, but also in part because these pattern-based measures can be more sensitive to local distributions of neural patterns and microvasculature. So this is a simulation with 2 different types of neurons that are intermixed, and they have different functions, presumably, call them type 1 and type 2. When we sample MRI voxels, we sample them very coarsely, maybe about 5.5 million neurons per voxel. That's a lot. But if you look at this, the distribution is different, just by chance, in every voxel. So if we estimate what the local field potential might look like for each type of neuron, we can see that they look different. And if we sample those into patterns of activity, we can see here that even though there's no single voxel that shows a strong signal for type 1 versus type 2, the pattern as a whole can differentiate them. In some cases fairly well. Doesn't mean it's always going to work, but sometimes it can work. The next wave of studies, and one of the important directions, is to optimize these patterns for convergent and discriminant validity. So to take this seriously as a measure. I'll show you what I mean by going back to the anterior cingulate cortex as an example. So the anterior cingulate cortex, as I've told you, is functionally diverse. It responds to many things: pain, cognitive tasks, emotional tasks. And that's led to a number of general theories of cingulate function, i.e. there must be something that this does that we can capture. That's a common baseline across all of these things. Many proposals, including effort, conflict, action value, expected value of control, or maybe just things that are survival relevant. On the other hand, if we look at the neuroscience literature, what we see is that there are separate neural ensembles within this region for diverse motivational functions, including pain and neurons that respond differentially to different types of pain on different body sites. Response selection, so that the neurons that change their properties as a monkey moves from valuing one thing to valuing another thing. Valuation of actions, onset and offset of foraging behavior, and others. And so that might lead us to a multi-component theory of cingulate function. We need not find one thing that explains all of the fMRI signal in the cingulate cortex. And the real question then is, can imaging separate that out? So this is a little bit about the construct validation process. What we want to have is a systematic sampling of diverse measures of a potential construct. So if this is pain, we might have thermal pain, mechanical pain, and visceral pain, which is often rectal distension, something that I don't do in my lab so much, but my colleagues fortunately do. That's why you have collaborators. And beyond pain, we have, in this study, we have 270 participants across 18 studies that are systematically sampled. So we have 3 types of pain, 3 types of cognitive control, and 3 types of negative emotion. And they vary in modalities as well. So some of them are elicited by sounds and some by pictures, etc. And we have 2 studies of each type, so we can establish generalization across studies as well and test if it's study specific. I'm just showing you a drop of the results because I'm going to tell you about a lot more, but there's lots more in the paper, of course. And the point here is that when we look at the patterns across these, what we find is that the patterns for these 3 domains are in fact quite different, dissociably different from one another. So there is a pain-related pattern. In fact, there's a pain-related pattern that tracks pain across thermal, mechanical, and visceral types. And so that's a generalizable representation of pain that's not shared with other domains. Incidentally, for cognitive control and negative emotion, we found activation, we did not find a generalizable representation, i.e. a common pattern that explains all of these different, responds in common to all these different types of negative emotion or cognitive control. There are other areas in the brain that do encode those common patterns for those other domains, but not here. A second really important direction to go is to think of multiple pathways. The NPS is one measure. There's no claim that that can capture all kinds of pain, and in fact it shouldn't. Pain is incredibly diverse. So we essentially removed stimulus intensity from this study. This is actually a compilation of 6 studies, 180 people, and we built a model that predicted pain once you get rid of the variation associated with stimulus intensity and the NPS. And this is what we get. It's a pattern of activity in other areas of the brain. Some of them, like this frontostriatal system here, that do not respond to increasing noxious stimulus intensity at all. So they're really non-nociceptive, and yet they predict how much pain a person is going to report on a trial-by-trial basis. In fact, here you can see each dot is a person, so across the 180 people, and we have separate test data sets and so forth as well, but you can see that there's a really reliable relationship. In fact, the slope between brain activity and pain ratings across individual trials is positive for 98% of our sample. Explains about as much variance as the NPS in pain ratings. And there is fine-grained sort of differentiation of some of structures like the nucleus accumbens here, where there is a shell-like and core-like area which is associated with more pain that's yellow and less pain that's blue. So, you know, we'd like to avoid treating the nucleus accumbens as sort of one unit of analysis and test these finer-grained patterns as we move forward. And this shell-like and core-like is actually based on work by Vani Abkarian's lab with Marwan Baliki and Paul. Okay. So another thing about this system, this frontostriatal system, is that when we ask people to self-regulate pain, imagine it's burning, bubbling, itching, terrible, or warm blanket on a cool day, this is the system that mediates that effect. That's the strongest and really the only convincing mediator we found. So if you rethink pain as better, the accumbens goes up. The more the accumbens goes up, the more the MPFC goes up. And the more that happens, the more pain goes down. That also parallels other work in emotion regulation by our group and others. And so the interesting thing, if we turn back to clinical pain, is this idea that once pain has become chronic, these prototypical nociceptive systems that are captured in part by the NPS are no longer the most relevant systems for many people. So this is from Baliki and Abkarian's group again, and Javeria Hashmi. The idea is acute pain is characterized by activation in nociceptive systems, but chronic pain is characterized by a shift to what you might call more emotional systems, although we have a little bit different view of that. But they're systems that involve the medial prefrontal cortex. We think that this frontostriatal system is really important in pain because it is in part a system for avoidance learning. So this is a snapshot from an earlier paper that we did with a lot of modeling involved. But the long story short is we identified a model of pain avoidance learning in which the ventromedial prefrontal cortex, here you see in green, contains a signal that is about the predicted avoidance value, how good an option is when you make a choice, A or B. And that's compared in the PAG, in the midbrain, with noxious input coming in. A prediction error is generated, which does two things. It updates the value representation for what you should and shouldn't do, which might lead to pain or not, and it updates action policy representations in the anterior cingulate cortex that help you avoid the bad things. There's a deep relationship with opioids in the PAG, which cancel out pain essentially when expected in some animal models. And so there's this idea that we'd like to test that persistent opioid use might actually cause dysregulation in this circuit, which makes people hyper-avoidant. That's a whole other story. But that's, I think, why we think it's important. I'm going to come back to this idea at the end, that pain has shifted in patients, many patients, from nociceptive problems to avoidance problems, fear and avoidance problems. Okay. So now go to this idea of treatment design. And I'm particularly interested in the psychosocial context, which is very rich. There are many elements to it: verbal suggestions, place cues, social cues, nonverbal social cues, specific treatment cues, and a rich internal context that includes expectations, emotions, pre-conceptual associations that you've learned in the brain between treatment cues and outcomes, and what I think is actually perhaps the most important, the meaning schema, a patient's idea about where he or she is and what the pain means, what the symptoms mean, and what's going to happen in the future. Are you going to be disabled for life or not, etc.? And this is something that's often an unconscious experience. So I like studying this because the context is ubiquitous. It's everywhere. Every social interaction is rich with it. It's the backdrop of all clinical interactions, which we can manage for better or for worse. And we can do this, and do this, on top of delivering other treatments that we might be interested in delivering, like surgery or pharmacotherapy. These are some psychological interventions that we've been studying from our lab, and there are many others. And I focused only in on pain here, but of course other kinds of outcomes, like decision-making, craving, other kinds of emotions and behaviors are also important. And I've grouped them into intrapersonal pain prediction here, manipulations of the expectations about pain intensity, or attributions of the meaning of pain. I'll show you that in a second. Self-regulation, so diverse strategies, including mindful acceptance, hypnotic suggestions, and training to basically rethink pain. And social context, including things like if you're being treated by a clinician who you think understands you and matches your values and similarity. We actually find that physical similarity in terms of race and sex or gender, etc., is not so important, but what is important is the perceived similarity in values. Whether you move synchronously, manipulations of social cues about what other people feel, and other things, including social touch. All of these things can affect pain in the directions that you might expect. But how much do they affect pain? For how long? Which should really be used clinically? Which kinds of training programs should be insurance reimbursable? How seriously do we want to take this, right? And one way of asking that is to ask which affect the brain mechanisms underlying pain. So to address that, we can use the lens of the NPS or any other available validated measure. And we can compare the effects of these various treatments. So I'll give you a snapshot of that. Now I'm going to turn back to this meta-analysis here with the 600 people. And we picked these studies because every one of these studies was about pain, but it was also about placebo effects. And it had a matched condition where people got pain without and with a placebo intervention that they were told was going to be pain relieving. And in fact, the shift to the left here, you can see across studies, virtually every study showed a significant reduction in pain with a placebo. That's in part how you get published, right? But that's pretty typical of what we see with a moderate effect size. But when you test the placebo effect on the NPS response, you get very little. Now, there is a significant reduction in pain. That reduction is correlated with the magnitude of analgesia across people. So I wouldn't say there's never any signal there in any case. I think some placebo effects are more powerful and others are not, and for some individuals. And I could tell you more about that later. But it certainly is insufficient to explain what's happening behaviorally in terms of people's report in any meaningful way. So this points to contributions from other systems. Okay, I have put a slide out of place. So I'm going to come back to it. There we go. All right, so let me now show you another kind of intervention. It's like a placebo, but there's some differences. So I think how you do the experiment matters a lot. So this is, we call this conceptual conditioning. There are two phases. Here, there's an expectation induction where people see these shapes. So this shape is paired with pictures of thermometers that are low. I should show you the thermometer here. Sorry about that. But in this one, pictures of high thermometers. So people learn this conceptual association in which we tell them low thermometer means low pain later. High thermometer means high pain later. So they learn that association, but there's never any primary reinforcement. And then, later, they get a test. And in the test, they get the same shapes followed by actual thermal pain. The pain itself is identical across the different cue conditions. So there's never any systematic reinforcement of one cue or another. And because these cues are never reinforced, people ought to be able to figure it out pretty quickly, and they should extinguish. Right? Those cues don't mean anything. The blue, the blue is low cues, and the red is high cues in the next slides. So we can see what happens with a low cue. You get a nice increase in pain with the stimulus intensity. But with the high cues, it's much more painful for virtually everybody. Now, this is self-report. What about autonomic activity? We can see the same thing. There's a robust response in skin conductance to cues that tracks the stimulus intensity. And with the high pain cues, the response to the equivalent stimulus is much larger. And now we can see over time, these are people's expectation ratings over time during the test and their pain ratings for the high cues in red and the low cues in blue. And you can see that both their conscious ratings and the effects on pain do not converge over time. They do not extinguish. They persist in both studies here. So there's no extinction. Initial expectations are maintained without any reinforcement. We have a model in this paper of why that might happen. We think that we have created the conditions for a self-fulfilling prophecy and a confirmation bias in learning. There's two mechanisms that perpetuate pain, and that can actually cause large effects. But for the models, you'll have to go back to the paper because I'm going to move on to another intervention. Before I do, I want to show you this. This is the brain responses now. So high Q versus low Q produces robust activity in lots of areas, right, during pain. Many of them are pain-related. When we apply the NPS, we do, in fact, validate sensitivity to intensity, and the NPS response is higher with a more intense stimulus. So we think this is a case, and there are specific procedures that can create this kind of robust effect, including effects on the best pain-related measures that we have now. Okay, and that's something that can be capitalized on clinically. So here's another example. This is an example of a social intervention now. And this is a Buddhist idea. How many of you have ever had a child who hurt themselves or something else, and you just thought, I wish it were me, and I could take on their pain? Me too. And this is, and this study came about based on a conversation I had at one point at a meeting with Mathieu Ricard, who said, we Buddhists, we don't experience pain and suffering the same way because we choose to suffer and we nurture that suffering. I actually don't really remember what exactly he said to me, but it was something along those lines, and then the idea is then, does suffering for a reason make it more okay? And does it change how pain is constructed in the brain? So the idea is we created this study design where people transform pain with pro-social meaning by accepting it on behalf of a partner. So we first assess baseline pain, and then these were all women in the study in this case. They made a decision to accept pain on behalf of their male partner who was outside. We said, for every stimulus you decide to accept, we're not going to give them one. And you're going to experience those, and they get to choose between 25 and 75% of those cases. They were somewhere in the middle. There was a range, actually, from 25 to 75, But a lot of our sample actually went maximum pain, so they were really giving spouses. And so then we tested them with identical stimuli, but now they know that the stimulation is because their partner is being relieved. And then we test baseline pain again afterwards. Okay, so what we see in pain reports is a drop in pain intensity and unpleasantness. And you can see unpleasantness here. and the accept is in red, and the baseline is in blue. The lines are individual people. So there's an overall reduction in pain. It's rather modest. And we can split this up by whether the women chose to take very little pain, so they were sort of unwilling givers or willing givers, and they chose to take a lot of pain. And that's what you see on the left. The unwilling givers, very little effect on pain. But the willing givers are quite a strong effect. I think every person shows that effect. And now we can turn to the NPS, and we can again validate that it's working properly in this study. So there's no response to pain anticipation, basically threat cues, but there's a robust response to pain in every person in the sample in this case. And now we can look at what happens with prosocial acceptance. Nothing with the anticipation, and not much overall with the acceptance. But when we split it up into those, and that accepting pain goes with the whole constellation of increases in positive thoughts, increases in positive emotions, decreases in negative emotions. So here, when we stratify by the people who have low positive thoughts, they actually show an increase in pain. People with high positive thoughts, a decrease in I'm sorry, not pain, but NPS responses. Right, so that's the drop in the people who find this to be a very positive experience, accepting the pain on behalf of the partner. All right. So that's another piece of data to follow up on. We also did mediation analysis across the whole brain, asking where are the mediators that both respond to this condition differently and where activity predicts the reduction in pain. And those mediators include those in multiple systems. There's areas in the insula and the PAG and the anterior cingulate cortex. Those are, broadly speaking, nociceptive targets, although, of course, we don't know exactly what their specificity is, but that overlaps with the NPS. And there's also other areas, like the midlateral orbitofrontal cortex and dorsolateral prefrontal cortex, which come up repeatedly across studies as value-related, but are not nociceptive, per se. So these extra nociceptive areas. So now, we want to take this back to the clinic. I'll show you a work in progress, which is the results of our first clinical trial using a psychosocial intervention for clinical pain. And the idea is, and I won't show you brain results, by the way, not yet, they're still coming, but we have all the clinical results now. And the idea is that there are at least two potential pathways. One is, if you have peripheral or spinal pathology, you might show a higher NPS response or other similar measures, and that will be driving your increase in pain. But these frontostriatal systems, and perhaps others associated with fear and avoidance, might also be quite important for many patients. And if you have problem number 2, you don't want to get spinal surgery, for example. You need a different treatment. And a number of studies have shown that this is quite important. So there's a lot of work in the literature that suggests this, including correlations with spontaneous back pain in the medial prefrontal cortex, prediction of transition to chronic back pain from Apkarian's lab over a period of a year and even maintained to 3 years, a shift to more positive correlations between brain activity and pain in fibromyalgia. So we think that these mechanisms shift from anti-pain to pro-pain. And connectivity with the insula and cingulate in failed back surgery, and connectivity with the posterior insula in back pain. So there seems to be a shift towards more pro-pain responses across these studies and a number of others in the literature. So there's a shift in paradigm. The current paradigm is there's mechanical problems in your body, we just have to find what's wrong with your back. But the emerging paradigm is that, at least for some people, there's a major role of the brain itself. So treatment should also target the brain. And that's reflected in changes like the ICD-11's designation of primary pain, which doesn't have a structural cause. So might an intervention of meaning work to relieve people's clinical pain? So in this study, we have pre-treatment, a number of measures, including MRI. People were randomized. We have 150 patients, and they were randomized to no treatment or treatment as usual. We followed them. An open-label placebo injection, which is a placebo injection in the back designed to mimic an epidural steroid, but we told them they were getting a placebo, and they understood that. which has worked now in several clinical trials of back pain, which is why we decided to go for this, and a psychotherapy arm. I'll tell you a little bit more about that. And then we have post-treatment MRIs and other measures as well. The placebo injection is subcutaneous saline for various reasons, because actually injecting, people think the lavage of injecting saline into the back actually might work above and beyond the belief. So we wanted something that was purely about the psychosocial context. So there's some neuroscience education that the brain is powerful and can affect pain. There's verbal suggestions of improvement. There's some social norms that people can improve. A caring physician, that you can see her there, Karen Knight, did all of these interventions with a sort of standard workup that she does. So a number of elements to that. The psychological intervention we called pain reprocessing therapy, and my brief explanation of how it works turned out to be 4 E's. So there's an explanation or a narrative, which is that pain for many people is a false alarm. It's caused by central sensitization in neural circuits and not by tissue damage. So the expectation is that yes, you can actually be cured, which is very different because many psychotherapists now who practice CBT or ACT or rational emotive therapy or dialectical behavioral therapy or a number of other therapies, they're not pain physicians. And so if a person says, my doctor told me that if I move this way, I'm going to be disabled for the rest of my life, and I need surgery and my pain's never going to get better, the psychologist is not going to say, no way, trust me, you need to move this way, right? So they don't. What they normally say is, you're always going to be in pain and you're going to have to live with it forever. And some of our patients in the videos said exactly that. Their surgeon said, if you move, if you don't, then you're always going to be in pain, your spine's going to degenerate, and you're going to be in pain for the rest of your life and disabled. So that's a nocebo, a negative expectation. But here, what we're telling people is that, yes, because your pain is linked to fear and avoidance, you can be cured. Then there's exposure. So there's a program of somatic and emotional awareness where you sort of get back in touch with your body and experience it, and also do the thing that makes it hurt, because it's okay. And this requires a very fine touch. I think you need to be a gifted therapist to probably pull this off. And then there's engagement, which is a program then of increased physical activity and return to normal activities. It's not physiotherapy per se, which also can be effective, but that's the idea. So let's look at how it worked. So here's baseline to post-treatment. For no treatment, people get a little bit better. With the placebo, there is a significant improvement, but it's small. Open label placebo. And with the therapy, there's quite a large effect. And if you look at it this way, these are the individual patients, the change from baseline without treatment, with the placebo, you can see a shift down, and with the psychotherapy. And the average percent improvement is here, 20, 35, and 70% improvement. You can also quantify this by asking who is pain-free or nearly pain-free at the end of the session. And so they report no pain, and it's 10%, 23%, or 75% of people in the treatment group were pain-free or nearly pain-free. And we can compare those effect sizes here to other kinds of standard treatments. And we can see, actually, first, that there's a medium effect here of placebo. It's a medium size, right? And a large effect or very large effect of the psychotherapy. In the literature, if you look at multidisciplinary treatment versus waitlist, the effect sizes are edging toward the large, they're close to 1. CBT versus waitlist, they're a little above 0.5. Yoga, treatments like that, a little above 0.5 as well. So the open label placebo is nearly as effective as many of these more expensive treatments. But the psychotherapy really works much better. So I hope you'll stay tuned for the brain results, which are coming at some point here soon. But I'd like to turn back and wrap up here by just saying that we've shifted in the field from thinking about pain as something that happens to you and the brain just kind of registers it, to thinking about the symptom as an emergent property that is constructed by the brain. in part from nociceptive input and in part from other sources. And I think that that's the story for other kinds of symptoms as well. So there's an active inference process that's made by the brain. And as a result, we can consider psychological interventions alongside other physiological ones, and it won't hurt. So I'd like to leave you with this quote from René Dubos, the discoverer of the first clinically used antibiotic. Modern medicine will become really scientific only when physicians and their patients have learned to manage the forces of body and mind. I'll say thank you to my lab, who's been great, and there's more people there, and also to the many collaborators, most of whom I hope are here across the world, who have shared data with us to test and develop these pain signatures and validate their sensitivity and specificity and generalizability, which has been really a lot of fun. And finally, I'll say thank you to our funding sources, and thank you to you for your attention.